hemostasis. Now, when you talk of disorders of hemostasis, you've got disorders affecting either the blood vessels, which means a defect in the vascular endothelium, or a disorder involving the blood vessel wall. It can be a disorder involving the platelets or a disorder involving the coagulation factors. Now, if there is a bleeding disorder because of a problem involving either the blood vessels or the platelets, this is what is called a primary hemostatic disorder, okay, or a disorder of primary hemostasis, okay, disorder of primary hemostasis. Whereas if it is due to a problem with coagulation factors, you call it to be a disorder of secondary hemostasis, okay, secondary hemostasis, okay. So any bleeding disorder can be grouped into a primary hemostatic disorder or a secondary hemostatic disorder. You've got to understand that whenever there is an injury to a blood vessel, what are the sequential steps that take place? The first step is often a vasospasm. Okay, first step in response to a vascular injury is a vasospasm, followed by formation of a platelet plug, okay, platelet plug, which is the primary hemostatic plug, and subsequently you've got activation of the secondary hemostasis resulting in the formation of a fibrin plug, okay. And as I told you before, when you get a disorder involving these initial steps, you will have a primary hemostatic disorder, whereas secondary hemostatic disorder affects the later part, okay, right. Now let's move forward and discuss in brief regarding what is actually the primary hemostasis. So primary hemostasis, what I want you to understand is, just have a look at this picture. You can see intact vascular endothelium, yes. Now I just want you to have a look at the von Willebrand factor, okay. So where is the von Willebrand factor located? You've got the subendothelial von Willebrand factor as well as the circulating von Willebrand factor, right? So when you have an endothelial injury, there is a vascular injury, there is a damage to the endothelium, what will happen? You will have the subendothelial collagen being exposed, okay? So subendothelial collagen is being exposed. Now what will happen? There will be an interaction of the platelets with the subendothelial collagen. So how is this interaction taking place? Now this is very interesting. You look here, you can see here, this is the subendothelial von Willebrand factor, right? So this subendothelial von Willebrand factor, what happens is, in the surface of the platelets, there are various receptors, and you've got one receptor that is the glycoprotein, that is the GP1B9 receptor, okay, the GP1B9 receptor. So this, with the help of the GP1B9 receptor in the surface of platelet, which binds to the von Willebrand factor, okay. So what happens is that the von Willebrand factor will serve as a bridge between the subendothelial collagen and the platelet, okay. So what will happen as a result? You will have a platelet adhesion, okay. You will have a platelet adhesion which is mediated by the glycoprotein 1B, the glycoprotein 1B9 receptor, okay, 1B9 receptor. So that mediates platelet adhesion. Now what happens? Next, what should happen is, as a result of the platelet adhesion, the platelets get activated, and the platelets releases certain chemicals like ADP, thromboxane A2 and calcium. Okay, ADP, thromboxane A2, calcium, because obviously the platelet contain these in their granules and these are released. And the release of these chemicals like ADP and thromboxane A2 will invite other platelets to the site. Okay, so other platelets also get attracted to the site and you will have a platelet aggregation now happening. So how does the platelet aggregation happen? You can see it is with a different receptor. Okay, so you've got platelet aggregation, which takes place with the help of a receptor that is GP2B3A. Okay, so with the help of a receptor, glycoprotein 2B3A, and you can see that this receptor GP2B3A, so adjacent platelets are binding to each other. And how does this happen? Again, there is another bridge here, which is the fibrinogen. So fibrinogen is bridging adjacent platelets and you are having the platelet aggregation that is happening and you get a platelet plug because of this. Okay, as a result, there is a formation of a platelet plug, which is the primary hemostatic plug. Yes or no? Primary hemostatic plug. Okay, and after that what happens is, you have got activation of the secondary hemostasis. You have got, these calcium and all can trigger the coagulation cascade as well. Okay, so I hope you understood what happens in the primary hemostasis phase. Okay, right. Now what about secondary hemostasis? Is mediated by the various clotting factors. You have got the extrinsic pathway, the intrinsic pathway and the common pathway. Currently, you have also got views of a cell-based pathway as well, but I'm just restricting my discussion to the classic description of the extrinsic pathway and the intrinsic pathway, and you've got the common pathway. So you've got multiple clotting factors which are being involved in secondary hemostasis, and when you get a defect in any of these clotting factors, you can have a disorder involving the secondary hemostasis. Okay, right. Okay, so just to sum up, a bleeding disorder is a disorder of hemostasis which can happen because of vascular disorders like scurvy, which is going to affect the integrity of the blood vessel wall, small vessel vasculitis like a Henoch-Schönlein purpura, platelet disorders which can be a quantitative defect, which means there is a thrombocytopenia. Okay, thrombocytopenia, for example, which can happen because of an infection like dengue. Okay, so you can have a decrease in the number of platelets. Similarly, you can have a qualitative defect. Okay, so what is a qualitative defect? See, one example of a qualitative defect is von Willebrand disease. Okay, von Willebrand disease, wherein you do not have the von Willebrand factor available, because of which the primary hemostasis is not taking place properly. So the platelet function is being affected. Okay, platelet function is being affected despite a normal platelet number. Okay, so that happens in von Willebrand disease. And then you've got a disorder known as Bernard-Soulier syndrome. Okay, you've got a disorder by name Bernard-Soulier syndrome, wherein the defect is in a glycoprotein, that is the GP1B9 is defective. Glycoprotein 1B9 is defective in Bernard-Soulier syndrome. So what is going to happen? This receptor is defective, glycoprotein 1B9. So because of which platelet adhesion is not going to take place properly. Okay, so it is basically an adhesion defect. Okay, so it's basically there is an adhesion defect. Okay, platelet adhesion is defective. Okay, adhesion is defective. Okay, now another disorder where you get a qualitative dysfunction of the platelet is known as Glanzmann Thrombasthenia. Okay, Glanzmann Thrombasthenia. So what happens in Glanzmann Thrombasthenia is there is a defect involving the receptor glycoprotein 2B3A, which is important for platelet aggregation. Okay, so here what is defective? The platelet aggregation is defective. Okay, platelet aggregation is defective. Okay, because of which, despite a preserved platelet number, the function is affected. Okay, so you can have a disorder of hemostasis. Okay, then coming to the coagulation disorders, which can be congenital. For example, the various hemophilias. Okay, the hemophilia A, hemophilia B, hemophilia C. Okay, the hemophilias. Then acquired coagulation disorders, multiple examples are there. I'm just giving you an example of liver disease. So patients with liver cirrhosis, especially in the decompensated stage, since the liver is important for clotting factors 2, 7, 9, 10, you can have a defect in the production of these clotting factors, resulting in, again, a coagulation disorder. Okay, and also, acquired coagulation disorder can be because of certain drugs, anticoagulants, which can produce coagulation defects. Okay, so basically the first two disorders, the vascular disorders and platelet disorders, are disorders of primary hemostasis, whereas the coagulation disorders are disorders of secondary hemostasis. Okay, primary versus secondary. Okay, right. Now, as I told you earlier, this module is basically on the approach to such disorders, and in questions, how do you diagnose? See, a couple of basic points. In platelet abnormality or a vessel wall abnormality, that is a problem with primary hemostasis, you are more likely to get bleeding into the skin and mucous membrane. Okay, and as a result of which, patients can have petechiae, purpura, ecchymosis, and ecchymosis which are mostly superficial ecchymosis, epistaxis, gingival bleeding, menorrhagia, and rarely hematuria. Not very common, rarely hematuria. Okay, so this happens because of a disorder of primary hemostasis, but unlike primary hemostasis, patients with disorders affecting secondary hemostasis are likely to have bleeding into deep tissue, joints, and muscles. Okay, this is what happens in a coagulation factor defect. So you get large ecchymosis, often deep ecchymosis. So ecchymosis can be there in primary hemostatic defect and secondary hemostatic defect. It's often a deep ecchymosis in case of a secondary hemostatic defect. You can have large hematoma, and hematomas into the joints, hematomas into the muscle, and you can have a delayed bleeding. This is important. Suppose you have got a trauma. Somebody was playing a football, he fell down. There is immediately he had no other problem. After a few hours, okay, then only he starts developing swelling around that knee joint. So this is because the immediate response is often the primary hemostasis, right? And then only he develops this secondary hemostasis. Then you can have this delayed bleeding as a part of secondary hemostatic disorder. Okay, so watch out for this point, especially in MCQs. This is a disorder affecting the secondary hemostasis. Now, just for you to know, like the distinctions between petechiae, purpura, ecchymosis. If it is less than 4 millimeter, you call it petechiae. 4 to 10 is purpura. More than 10, that is more than 1 centimeter, is what you call as ecchymosis. Okay, so this is how you roughly classify based on the size. Now, just have a look at this. These are petechiae, purpura, and ecchymosis, mostly suggesting a primary hemostatic disorder, except a deep ecchymosis, which may be seen in a secondary hemostatic disorder. Whereas if you get a bleeding into the joints, bleeding into the muscles, it favors a secondary hemostatic disorder. Then the next point is, once you identify it is a primary or a secondary hemostatic defect, you've got to see, is it an inherited problem or an acquired problem? So you can have inherited causes as well as acquired causes. So how do you know if it is an inherited cause or not? So if you have got in the question any sort of history of a childhood history of epistaxis or umbilical stump bleed or bleeding after circumcision, then excessive bleeding during menarche, or a history of cephalhematomas or subgaleal hemorrhage following delivery, or a history of neonatal IC bleed, if anything of that sort is mentioned, it is likely to be an inherited bleeding disorder. Family history is also important in a case with bleeding disorder. That can definitely help you solve MCQs as well. Now let's take, for example, suppose it is X-linked inheritance. For example, hemophilia A and B. Okay, They are having X-linked pattern of inheritance, hemophilia A because of a factor 8 defect, hemophilia B because of a factor 9 defect. So here you will have predominantly, along with the patient, a male sibling is affected, or maybe a maternal uncle, grandfather. It's commonly in males. Whereas what about autosomal dominant bleeding disorder? So here there will be good penetrance among families. Either the father or mother may transmit the disease, and most of them will have disorders of primary hemostasis. They're having mucocutaneous symptoms. As I told you, mucocutaneous symptoms are more common with primary hemostatic defects. For example, von Willebrand disease. Okay, von Willebrand disease type 1, 2A, B, M, 2A, 2B, M. Okay, so these are likely to have mucocutaneous symptoms. Whereas if you take von Willebrand disease type 3, okay, they are likely to have disorders involving the secondary hemostasis, because the level of factor 8 is very much reduced, and which I've discussed in detail in the module on the von Willebrand disease. Okay, so here it is autosomal dominant. Classical example is most of the von Willebrand disease. Then coming to autosomal recessive. So here mother or father may be the carrier, okay, because you can have the disease which are skipping generations. So the mother or father may actually transmit the disease without having obvious manifestations. But watch out for the history of consanguinity and autosomal recessive. Examples are von Willebrand disease 2N, 3. Then Glanzmann's thrombasthenia, which happens because of a 2B 3A defect, and Bernard-Soulier syndrome, which happens because of a 1B 9 defect. Okay, so that is important. Then acquired bleeding problem can happen because of various infections like dengue fever. It can happen because of leptospirosis, malaria, then chikungunya fever, scrub typhus. Lot of acquired bleeding problems can have, infections can have thrombocytopenia. Kidney disease, as a part of uremia, you may get bleeding because of either a platelet dysfunction or even because of a clotting factor abnormalities as well. Drug history is very important because many antiplatelets, anticoagulants, they can cause bleeding. Antiplatelets, anticoagulants. Okay, connective tissue diseases like SLE, APLA syndrome. Okay, watch out for them. Liver disease, again important, factors 2, 7, 9, 10 produced from liver. You can have bleeding problems. Hematological malignancies, the leukemias, they can have AML, ALL, they can have bleeding problems because of associated thrombocytopenia as well. Okay, right. Next, having understood the basic points regarding the approach, let's quickly have a look at the various tests for assessing the hemostasis. So tests for primary hemostasis, tests for secondary hemostasis. In primary hemostasis, you have got to assess the platelet number and function. So you look at the complete blood count, which will give you if there is a quantitative defect in platelets, is there a thrombocytopenia? And also it helps you to assess whether any other component of the complete blood count is abnormal. As I told you earlier, in certain leukemias, you can have associated thrombocytopenia. So you will have associated abnormalities in the WBC count as well. The peripheral smear is also important, which will give you an idea about the morphology of the platelets, because certain platelet disorders can have abnormality with regards to the morphology. Giant platelets may be seen in Bernard-Soulier syndrome. Small platelets may be seen in Wiskott-Aldrich syndrome. And you've also got to exclude pseudothrombocytopenia. If you take a blood sample with EDTA can cause clumping of the platelets. So if you just look at the count, it might actually spuriously show thrombocytopenia. But when you look at the peripheral smear, you will see all the platelets being clumped up. So which will tell you, it is a pseudothrombocytopenia. Then you can go for bleeding time, which is in fact an indirect reflection of the platelet function, or you can go for a platelet function analyzer, which will tell you the time required for a platelet plug to be formed and the time it takes to obstruct the blood flow, which is known as the closure time. And then you've got the platelet aggregation studies. You've got the Ristocetin-induced platelet aggregation study, ADP-induced platelet aggregation study. So in Ristocetin-induced platelet aggregation, wherein the interaction between the glycoprotein 1B9 receptor and the von Willebrand factor is assessed. So if you have a von Willebrand disease, wherein the von Willebrand factor is reduced, or a Bernard-Soulier syndrome where you do not have the 1b9 receptor. In these, what will be defective? The restocytin-induced platelet aggregation will be defective, whereas the ADP-induced platelet aggregation ADP-induced platelet aggregation will be defective in Glanzmann's thrombasthenia. Okay, so in Glanzmann's thrombasthenia, because the subsequent aggregation happens as a result of release of ADP and all, so that will be defective in case of Glanzmann's thrombasthenia. Okay, right. So because you do not have the receptor. Okay, you do not have the GP2B3A receptor, which is why it will be defective. Okay, right. Then abnormalities of blood vessel, you have got bleeding time, which will be prolonged. As I told you earlier, platelet disorder, you will have prolongation of bleeding time. Blood vessel disorder, you will have a prolongation of bleeding time. What about when the von Willebrand factor is affected? Obviously, again, the primary hemostasis is affected. So bleeding time will be prolonged in all cases of primary hemostatic disorder. The only advantage is that here in case of platelet disorder, you can additionally go for a platelet function assay. So you've got the PFA 100, PFA 100, PFA 200, which will help you assess the platelet function. Okay, right. So von Willebrand factor, I'm not discussing in detail. I've discussed it in the von Willebrand disease module. You can assess the von Willebrand factor antigen, restocytin cofactor assay, von Willebrand factor multiple analysis, and also the factor 8, because in circulation, the von Willebrand factor is bound to the factor 8. Okay, so it will prolong the half-life of factor 8 as well. What about the test for secondary hemostasis? You have got the prothrombin time. So if you look at this, you have got here the extrinsic pathway, intrinsic pathway. So in extrinsic pathway, the assessment is the prothrombin time. So extrinsic pathway, the isolated prothrombin time prolongation will happen in an extrinsic pathway defect, whereas an isolated APTT prolongation will happen in an intrinsic pathway defect, whereas in a common pathway defect, both prothrombin time and activated partial thromboplastin time will be prolonged, okay, in a common pathway defect. So activated partial thromboplastin time, normal for prothrombin is 10 to 12 seconds, APTT normal is 28 to 36 seconds. So then you have got the thrombin time, so wherein it is a time taken for the soluble fibrinogen to be converted to the insoluble fibrin clot. The normal one is 12 to 15 seconds. Then you have got fibrinogen levels, which will be decreased in certain conditions like afibrinogenemia, which can be a disorder of secondary hemostasis. The fibrin degradation products and D-dimer will be increased in case of disseminated intravascular coagulation. And what about the role of mixing studies? Again, important. So what is the role of mixing studies? So mixing studies actually help you in, it is something that you should do in suspected secondary hemostatic disorder, wherein you will be able to know whether the reason for the clotting time prolongation is due to a clotting factor deficiency, or is it due to an inhibitor? For example, lupus anticoagulant. So patients with APLA syndrome will have a lupus anticoagulant. So the prolongation of APTT is because of the lupus anticoagulant and not per se because of a defect in a particular clotting factor. So to perform a mixing study, what you will do is that you will mix the patient's plasma with the normal pooled plasma, and then you measure the clotting time that was initially prolonged. Okay, now suppose if this is correcting, so you added a normal plasma which actually now has the clotting factors. So if the initial patient plasma lacked the clotting factors and your normal pooled plasma has the clotting factor, obviously the clotting factor should correct. So that indicates a factor deficiency. But suppose if it is not still getting corrected, what does that indicate? Because if the patient's plasma is having a clotting factor inhibitor. So even if you add a normal pooled plasma containing the clotting factor, this inhibitor will inhibit it. So because of that, what will happen? Again, there will be a prolongation. It will not correct, it will keep being prolonged itself. Okay, so this you have to know about the importance of mixing studies. So this is how you will approach a case of bleeding disorder, and you can expect questions based on the various disorders of primary and secondary hemostasis.